Go ahead.
Yeah. So good evening, everybody. Welcome all to the another section of the educational series by INDEPSO and ISPSM. And today we are here to discuss uh, one disease which is known to be very complex in its heterogeneity and further complicated by the development of peritoneal disease, as we all know. And today we are going to discuss GASTRIPEC, the randomized control trial by Dr. Mufaddal Qazi, who is an associate professor and consultant surgeon at Tata Memorial Hospital, Mumbai, the colorectal unit, and with a keen interest in minimal invasive as well as peritoneal surface oncology. Over to you, Dr. Qazi.
Thank you, Dr. Aruna. Thank you, Dr. Aditi, for organizing these events. So today we'll be talking about the GASTRIPEC 1 trial. And let me move the slides. Yeah, okay. So before we start criticizing the trial, we need a word of appreciation for the investigators, the authors. It's a mammoth task to conduct prospective randomized trials, phase 3 trials, multi-center trials, coordinating between centers, and so we need to appreciate the work that has gone through before we start criticizing the trial. So let's begin with the background of the study. So gastric cancers and peritoneal metastasis are significant problems. Even in radiologically M0 patients, about 30% will have occult peritoneal metastasis at the time of staging laparoscopy, even in locally advanced gastric cancers. And this is the MSKCC study, which says 31%, which forms the basis of recommending staging laparoscopy routinely before neoadjuvant chemotherapy. Now, for peritoneal metastasis, there have been 3 randomized trials before the GASTRIPEC 1, comparing cytoreduction and HIPEC with cytoreduction alone. However, most of these were from Asia, small numbers, and this is the largest one that was there. That it was 68 patients, 34 in each group, median PCF of 15 in chemo-naive patients. And it had a mix of both synchronous and synchronous and metachronous peritoneal mets, and using HIPEC with cisplatin and mitomycin. There was near doubling of overall survival from 6.5 to 11 months with the use of HIPEC. The next big study is the CytoChip study, as we are all aware of from the French network. 277 retrospective study. The balancing between groups was done using inverse probability of treatment weighting. Here, the median PCA was 3. That's why we see a better overall survival in general. And yet again, HIPEC improved the survival by at least 50% from 11.5 months to 18.5 months. But yet there were a lot of issues. There was doubling of survival, yet the overall survival is very dismal because peritoneal metastasis in gastric cancer is a very aggressive disease. There was no PCI cutoff used, but based on these studies, we tend to believe that a PCI of less than 6 should be okay. The sample sizes were usually small. Perioperative chemotherapy was not standard. And majority of the prospective studies come from Asian studies only, which means largely distal gastric cancers rather than proximal stomachs. So the investigators believed that another trial was necessary, and thus the inception of GASTRIPEC 1. So the objective was very simple: to compare the overall survival of gastric and esophagogastric cancers with synchronous peritoneal metastasis without other distal metastasis treated with cytoreduction or cytoreduction and HIPEC, but this time both arms would have perioperative chemotherapy. So coming to their methods, the hypothesis was that surgical cytoreduction with intraperitoneal chemotherapy would be superior. So it's a superiority study, and the primary outcome would be overall survival. So it was a prospective study, randomized with allocation ratio of 1:1. It was open label. There was no blinding. Multi-center, 26 centers in Germany, all in Germany, contributed to the study. And it was parallel group. Obviously, there were no crossovers. Now, the allocation it is not a simple randomization. So they stratified by center, HER2 status, and by PCI subgroups. Now, stratification is important when you're expecting a small sample size to avoid imbalances between groups. And the method of stratification and allocation was the modified Pocock, which is a type of dynamic allocation. Whether it is good or bad is a separate question. But usually for small sample sizes, you need some form of dynamic allocation method so that even if the study stops prematurely, you have groups which are balanced. The inclusion was 18 to 75 years, gastric, esophagogastric cancers, biopsy confirmed synchronous peritoneal metastasis, which means that all patients should have had a surgical staging. No distant metastases were allowed except for ovarian mets. And at the time of surgical staging, the surgeon should have 80% confidence in being able to cytoreduce the tumor. And the patient should have had no prior chemotherapy or radiation or any form of therapy before. Now, the control arm had 3 cycles of perioperative chemotherapy. It was EOX, the magic protocol for HER2 negative tumors, and for HER2 positive, it was CCT, cisplatin capecitabine, and trastuzumab. CRS would be performed 2 to 3 weeks later and would be supplemented with 3 cycles of adjuvant chemotherapy of the same regimen. The intervention arm, in addition, had HIPEC. The HIPEC was mitomycin 15 milligram per meter square, along with cisplatin 75 milligram per meter square, closed technique 40 to 43 degrees for 60 minutes. The chemotherapy, the perioperative chemotherapy regimens remained the same. Now, the primary outcome was overall survival. Important is that they started calculation from the time of randomization, which means before neoadjuvant therapy. Not from surgery, but from neoadjuvant therapy. And that is how it should be, that the calculation is always from the time of randomization. The endpoint would be death, or if they reach 2.5 years of follow-up. And importantly, patients would be censored if they could not reach the stage of cytoreduction. Therefore, suppose a patient progressed, did not reach cytoreduction, or reached on table but was found to be inoperable, their further event meaning death, their deaths would not contribute to the survival curve, and they would be censored at the time of cytoreduction. The secondary endpoints were many: toxicity, secondary surgical procedures, length of hospital stay, 30-day complications, quality of life at 6 months, progression-free, and other distant metastasis-free survival, other than peritoneal metastasis, distant metastasis-free survival. Now, sample size calculation was a little troublesome because they did not have any baseline. Since the control arm was cytoreduction, we did not have an estimate of what would be the survival of synchronous peritoneal metastasis who are treated cytoreduction alone. We have with palliative chemotherapy, we have with cytoreduction and HIPEC, but they did not have a baseline to calculate upon. They assumed about a 35% improvement in median overall survival, giving a hazard ratio of about 0.65 with 5% two-sided alpha, 80% power, and 2.5 years of observation period. So they expected that those many events would happen in 2.5 years of time. Now, because the randomization was before surgery, they expected an overall survival at about 4 months, which would be at around the time of surgery, to be around 75 to 80%, not 100%, because there would be progressions. And further, there would be 15% censoring, all of which was taken into account during the calculation. So with all that, 180 patients were calculated with a 3-year accrual period. The intention to treat analysis would be performed on the full set for the primary endpoints and the survival secondary endpoints. And next important point is that the survival curves were not compared using the log rank test, which is our convention. It was using the Fleming-Harrington test with a P of 0 and rho of 1 or Q of 1. Now, the Fleming-Harrington test needs some more clarification, because that is very important in how we interpret the results. It is not a log rank test. A normal survival curve would be a log rank test where an event occurring at any point during the follow-up would have equal weight. One would use a Fleming-Harrington rather than a log rank when we believe that later events would have more weight. That suppose we have an intervention like HIPEC, we believe that if somebody has an event too early after a cytoreduction and HIPEC, it is unlikely to be because of the intervention. We expect that giving intraperitoneal chemotherapy, the deaths occurring later could be better attributed to the intervention if they happen later. So in a Fleming-Harrington test, earlier events are given lesser weight, and events which happen later down into the curve or during follow-up are given more weight. So the sample size, just to give an idea, suppose there were 80% survival at 4 months, then they would have had to see an improvement in survival from 11 to 17 months, or if there was 75% survival, maybe from 9 to 13.5 months. They planned an interim analysis at around 90 patients, but we know because of slow recruitment, they had to stop at 105 patients, which is 58.3% of the planned sample size. An interim analysis would lead to alpha spending, and the first efficacy endpoint would be at an alpha or a P of 0.031 and a final of 0.028, but we never reached that stage. Now, because of the differing definitions of overall survival, the censoring, which was unusual, There were multiple sensitivity analysis done to convince that the results that we see are valid, irrespective of how we change the definition, how we censor the patients or not. So the first important sensitivity analysis was by uncensoring the patients if they stopped treatment before cytoreduction, which means even if they progressed and had deaths, their deaths would now contribute to the survival curve. What if we excluded patients when CRS was not performed, which is actually our point of interest? We want to see if cytoreduction or cytoreduction HIPEC worked, if they all reached the stage of cytoreduction. So they excluded patients if they progress before cytoreduction and then see what happens. Finally, also a Cox regression was performed to control for the factors that were stratified. And even in the PFS, a sensitivity analysis was done by including premature study termination as a PFS event. Now, all centers were not selected. It was only if a center could perform or was performing 20 cytoreductions and 10 HIPECs in a year, and the team had at least 2 visceral surgeons that were adept at performing cytoreductions and HIPEC. So with this, they had 26 centers which participate, 23 contributed patients, and Charité, which was the coordinating center, contributed 50% of the patients, while other centers probably 5 or 6 patients per center. The funding is well disclosed from the Charité University and from the German Cancer Aid. Coming to the results now, we know that the recruitment was from 2014 to 2018. It was a year longer than expected, and yet the required number
बैग ले जाना
could not be.
पुराने कपड़े है
They had 200
जो आएगा बाकी किसी को दे देना दो कपड़े दो शर्टों
Dr. Rudra, can you mute yourself?
Oh, sorry.
Thank you. So in 4 years of trial period, 281 patients from 23 centers were screened. 100 majority were found ineligible because of exclusions, and 105 were finally randomized, 53 into cytoreduction, 52 into cytoreduction and HIPEC arm. Now, the first thing that we see is that despite 53 and 52 being randomized, only 22 patients in the cytoreduction alone arm and 28 in the cytoreduction and HIPEC arm could reach the stage of complete cytoreduction. If we look at per protocol, that is even lesser, meaning they should have received 3 cycles of EOX or CCT and should have had completed adjuvant, should have the cytoreduction on time, should have HIPEC as per protocol. It was only 15 patients and 20 patients in the per protocol set that reached the stage of complete cytoreduction. So if we want to really compare it, we are comparing 15 and 20 patients in the entire study. Most common reason and most obvious reason was progression to unresectability, which led to this less than 50% patients reaching the stage of cytoreduction. The protocol violations were majorly because of the use of FLOT. FLOT had already come up by that time or midway between the study to be superior to EOX. And therefore, many centers started using FLOT after inclusion, and thus many patients had protocol violations. But these protocol violations, patients still contributed to the intention to treat analysis. Similarly, premature terminations were because of progressive disease, and that is in more than 50% of the patients. So the first inference before we come to the primary or secondary endpoints is that gastric cancer with peritoneal metastasis is a very aggressive cancer. And only 50% will reach the stage of surgery, majority progress. And to a patient, that is very humbling information. That if an unselected group of peritoneal metastasis plus minus distant metastasis, the chances or the probability that they may come on table is less than 50%. Let's come to the baseline characteristics now. It was well matched, randomized because of stratification as well. 50-50 male and female, median age of 55. Little less than 50% had a PCI of less than 6. Sizable number had PCI between 7 and 13 as well. 10% were HER2 positive. 100% had surgical staging as it was mandated by protocol. Now, importantly, signet cancers were there in 75% of patients. Not extremely unusual, but slightly higher than expected. Probably in M0 locally advanced gastric cancers, 30% would be an acceptable signet number. With peritoneal metastasis, because signet cancers have higher propensity for peritoneal metastasis, you can expect 50 to 60%, which is what previous studies also had, but this is slightly higher. And there is a difference between the groups here. 80% were signet cancers in cytoreduction alone arm, versus 70%. And this is not a small difference here. Similarly, grade 3 tumors were 83% versus 75, 76%. So there is some imbalance which is already occurring. The next is that despite inclusion saying that distant metastasis shouldn't be there, there were 20% patients with distant metastasis, not just Krukenberg's, but other sites of distant metastasis. And these were not clinically or radiologically occult disease. These were 40% patients who had presented with ascites. So we are not looking at radiologically M0 patients and found to have incidental peritoneal metastasis on staging laparoscopy. We are looking at a largely unselected group of patients, and which is the second inference, that the results have to be interpreted, understanding that we are looking at patients with distant mets, ascites, signet cancer, and without a PCI cutoff. So we cannot expect the results to be very great or the results to be very obvious between the two groups. Coming to surgery, complete cytoreduction was done in only 40 and 50% of the patients. Now, this is also an important difference. Why should there be a difference in the proportion of patients in the cytoreduction and the cytoreduction and HIPEC arm? The intervention has not happened yet. So it should be expected that similar number of patients should have progressed and reached the stage of cytoreduction. But here itself, there is about a 12% difference between patients who could achieve a complete cytoreduction, and which is likely because of higher signet cancers and higher grade tumors, and maybe more distant metastasis also, as we will see. Now, the amount of multivessel resection required were very few, which is how it should be in gastric cancer. Other than a gastrectomy or maybe a pancreatic tail resection, you don't expect a lot of multivessel resections, and which was balanced between the groups. The blood loss duration of cytoreduction was also similar, and the median PCI at surgery was 5, and which was same in both groups. Complete cytoreduction was also achieved in similar group number of patients and proportion of patients, and the total proportion of patients, if the denominator was all patients that underwent a cytoreduction, would be around 70% in both arms. The HIPEC was also as per protocol, 60 minutes, mitomycin and cisplatin, and temperatures well regulated. In the pathology, what is important is that despite neoadjuvant chemotherapy, 45% were T4 tumors. There were none, 0 N0 tumors, and 75% had viable peritoneal disease of those that reached the stage of cytoreduction, not of all the patients. And 18% had pathologically positive distant metastasis in the cytoreduction arm versus 7% in the cytoreduction and HIPEC arm. Again, a difference which is an imbalance, which shouldn't have happened. So third is that peritoneal complete regression rates are 15% or less, maybe 12.5, 15% with neoadjuvant chemotherapy in gastric cancers. And that before the intervention itself, the CRS and CRS HIPEC groups are different. Coming to the primary endpoint, let us look at this curve in detail. This is the overall survival curve. The numbers at risk are shown below. We begin with 53 and 52 patients. But what happens at 6 months of time? At 6 months of time itself, you have only 18 patients in the cytoreduction alone arm that will contribute to the further survival curve versus 27 patients. So you have 50% patients contributing in the HIPEC arm versus about only a third of patients which will contribute to the rest of the curve. And 6 months of the time is just when they would have recovered from surgery. They had surgery at around 3.5 months. At 6 months to see such a difference it cannot be attributed to the intervention. And the rest of the curve, they are going in parallel and they are going together. And then there are 2 or 3 patients that do not experience event or death in the HIPEC arm. And that is what makes that tail different from the cytoreduction alone arm, which is blue in color. So the median overall survivals are the same. And that significance testing also leads to a negative result. So the primary endpoint of median overall survival was negative. Both arms did same. The median overall survival was 14.9 months in both groups. 1 year survival was same, 2 year was a little different, 3 year, we see that there are no 3-year survivors in the non-HIPEC arm. And those 2 odd patients in the HIPEC arm continue to survive and finally experienced that event at around 6.5 years, 5.5 years, and there are no survivors beyond that. So the first sensitivity analysis was doing a regression using the stratification factors. So the HER2 and PCI trying to control for PCI and HER2 status, we still see that CRS and HIPEC did not fare better than CRS alone, since the hazard ratio here was 0.715 and the threshold was 0.65. The second sensitivity analysis, by removing the premature censoring. If you recall, at 6 months of time, you had only 18 and 27 patients. But if you remove the censoring, you have 36 and 40 patients. So now you have a better number of patients that will contribute to the survival curve. But there are many patients who have not actually received cytoreduction. Despite this, the survival curves go hand in hand. They are parallel. And again, those last 2 or 3 patients that survive in the HIPEC arm contribute to a slight difference in the tail of the graphs. Again, the p-values again do not reach significance, nor do the hazard ratios. The next is the secondary endpoint. The first secondary endpoint that we look at is the progression-free survival. Again, let's try to look at the graph and not the figures anywhere. You begin with 53 and 52 patients. At 3.5 months of time, not 6 months, 3.5 months of time, when the response assessment is done, you see a plummet of both arms in the PFS. So much so that in the CRS alone arm, the blue line, it already has dropped to 50% survival. The median is reached as 3.5 months before the intervention. It is only at response assessment scan or response assessment or at the time of surgery when they were found to be unresectable, they have progressed. While about 40% of the patients progress in the CRS HIPEC arm before the intervention. And that already has led to the difference in the graph. The difference that we see has set in at 3.5 months of time before the intervention, and which then moves parallel, the graphs move parallel, and the same difference continues at until around 2.5 years, when those 2 odd patients that did not experience event continued and contributed to the difference in curves. So again, looking at the numbers at 6 months, you have only 11 and 25 patients in these arms which have not experienced a PFS event. And again, I reiterate that at 6 months of time, you shouldn't be seeing this difference if it was truly because of the intervention. But here, the p-value using the Fleming-Harrington is 0.472, and it crosses the threshold for significance. Whether if a log rank was done, would it still have been significant is a question that we cannot answer unless we have the entire data sheet. What about, so the median PFS is 3.5 months in CRS alone arm and 7 months. And this difference is both clinically and statistically different. But the true question is it really because of the intervention? A PFS of 3.5 months, 50% progressing before the intervention, it cannot be attributed to the intervention alone. What about other distant metastasis-free survival? So yes, the p-value is again significant. It is 0.028. But what is the absolute difference? The absolute difference is 1 month. 9.2 months in cytoreduction alone arm versus 10.2 months when HIPEC was added to cytoreduction. May not be a clinically significant difference, but yes, it is statistically different. Now, just looking at the curve, suppose it was analyzed in a routine manner, I am not sure whether this would be significant or not. But because the Fleming-Harrington uses patients achieving event much later are given more weight, that additional weight would have contributed to a positive test on the Fleming-Harrington. Now, there are some planned subgroup analysis, which was CC0 and by PCI cutoffs. So if you have read the study, you know, the authors write in the manuscript that in the subgroup analysis for CC0 patients, cytoreduction and HIPEC arm did better. Let's look at the table that they have provided in the supplement. The median survival in patients that achieved CC0 resection was 16.5 months, while in the cytoreduction and alone arm is 15.5 months. It is a month less. Yet the p-value is significant and favors cytoreduction and HIPEC, counterintuitive. But they also provide upper quartile ranges, which is the best 25% of patients. And those best 25% of patients achieved a median survival of 23.7 months versus 33.7 months. And in the CC1 and more, you had 6.5 months versus 14.8 months difference in median survival, but the numbers are, we are comparing 6 and 9 patients, and probably which is why the p-value was not significant. Even in CC0, we are comparing 16 and 19 patients only. These are very small group of patients. And what does that mean about the best 25%, the upper quartile? It means 4 and 5 patients. We are comparing 4 patients versus 5 patients. Now, what would a curve look like? They haven't provided curves, and they have provided this limited data. With this limited data, I made some projections, and this is what the projection would look like. The blue dots are cytoreduction alone. The orange dots are cytoreduction and HIPEC. You see that at 50% at median survival, cytoreduction alone arm is doing better. And the best 25% or later events which are happening, which is probably those 2 or 1 patient, or maybe 2 patients in the cytoreduction alone arm that experienced a later event which caused the separation of curves, and which is why on the Fleming-Harrington you are having a significant value. Similarly, progression-free survival in CC0 versus CC1, no difference. Distant metastasis-free survival in CC0, again, different. Yes, different. 15 and 19 patients we are comparing, median survival of 10.6 months in CRS alone, 15.8 months in CRS and HIPEC, and you get a positive significance value. And the explanation is likely to be the same. Again, if you look at the best 25%, you are comparing 3 patients in CRS alone versus 4 in cytoreduction and HIPEC. If one patient had a different value, the entire curve would be reversed. Then there are a number of unplanned subgroup analysis. And for every possible factor that they had collected, male patients, female, HER2, EOX using a FLOT. More importantly, and a slightly counterintuitive, is that patients with PCI of 7 or more at the time of surgery seemed to have benefited with cytoreduction and HIPEC. Now the numbers again are, you're comparing 10 patients and 9 patients. And this is similar to what we had seen in the Prodigy 7. So this has implications for future trial plannings, that maybe a rigid PCI cutoff of 6 may not be too robust, and maybe we can relax the PCI cutoff a little. Similarly, even patients with CC1 or more seem to benefit with cytoreduction and HIPEC, although not significant. Now, these are unplanned analysis, so the chances of false positivity are very high. So too much significance cannot be placed on these results, but these are very, very, they are probably just for planning the future trials. Coming to the other secondary endpoints, toxicities, there were about 50% more derangement in lab values. There were more GI toxicities, more hemodynamic and more pulmonary complications. But again, the numbers are few and they don't reach significance value, nor did they reach the threshold for stopping the trial early. So they did not reach the safety threshold. Similarly, operative complications were nearly the same. There were no differences at all. And in the safety analysis of 50 and 50 patients, because they did not have data for 3 and 2 patients, there were no differences in any of the adverse events or adverse events that would relate to death. There are some other secondary endpoints for which we don't have much data, but just mentioned in the manuscript is that secondary surgical interventions were similar at around 18%. Length of hospital stay was also same, 15 and 13.5 days. And quality of life, without having to know what are the subsets, but it was similar at 6 months of time. So the conclusions are, one is obvious that gastric cancer pedal metastasis have very poor prognosis. 50% only will reach the stage of surgery, and even at surgery, only 70% could achieve CC0 cytoreduction. This is slightly less than what we have seen in the previous trials. About 85 to 90% should be okay in resectable peritoneal metastasis. Next is that median overall survival, which was the primary endpoint, was 14.9 months in both arms, which was not different. There was a difference statistically in progression-free and distant metastasis-free survival, but because of the reasons that I stated earlier, these are extremely unlikely that these differences are because of the intervention, which is HIPEC. There were slightly more complications, but it seemed to be acceptable, and HIPEC seems to be safe in gastric cancers. What about overall survival? Now, there was no influence. Now, why was there no influence? Probably it was because the groups were extremely unselected. You had distant mets, ascites, signet cancers, no PCI cutoff. The subgroup of CC0 also really did not show an effect. And the sample size overall was very small to observe a difference, even if there was one. The progression-free survival was different, but it is probably not due to HIPEC, nor was there any difference in the subgroups of CC0 and CC1 and more. And the difference, again, I keep saying this, but probably because of Fleming-Harrington. What about DMFS? How do you explain an improvement in distant metastasis-free survival with the local intervention? Obviously, we cannot discard the abscopal effect which happens with radiation, but we don't have information on the patterns of recurrence, the sites of recurrence, the volume of recurrence, which could have told us why there was a difference in distant metastasis. It could very well have been a random event, because we have to remember that we are talking about those last 2-3 patients which made all the difference. Suppose that 2-3 became 1, and we may not have seen that difference. And more importantly, the difference in DMFS was 1 month. And again, the Fleming-Harrington could have contributed to a significant p-value. The hard question is whether CRS and HIPEC is better than palliative chemotherapy alone. We know that in selected group of M1 gastric cancers, not just peritoneal, but any M1 gastric cancers with a good PDL1 score, with immune checkpoint inhibitors, 14.5 months of survival is achievable, which is similar to what we saw in this trial with CRS and HIPEC, with the added morbidity. So in an unselected group of all M1 patients, probably palliative chemotherapy may be okay. Then the use of EOX versus FLOT. We know FLOT is better in perioperative, FLOT may be better in M1 patients also. So we are really not sure whether in an unselected group of peritoneal metastasis, which also has a mix of distant metastasis, whether palliative chemotherapy is inferior to cytoreduction and HIPEC. And this is exactly the question that will be answered by the PERISCOPE 2 trial, comparing palliative systemic chemotherapy versus CRS and HIPEC. There are a number of limitations, and many of them I have already stated. We have already discussed them. But just once again, that allocation at presentation may be something that may be nagging many one of us. So they controlled for this. They expected 75% survival. They had about 60%. They censored patients until CRS. They provided differential weights. Everything was to balance out the allocation at presentation rather than allocation at surgery. The inclusion was too broad. It was very broad. It was unselected. And despite that, there were a lot of violations. And a lot of deviations happened because the centers were preferred giving FLOT rather than EOX. There were missing information, moleculars. Peritoneal response assessment could have been reported much better. Recurrent sites could have been given. There was poor accrual. Most centers actually contributed less than 5 and 6 patients. And the use of FLOT was supposedly the most important reason for poor accrual. Now, sample size. Although the sample size was calculated trying to account for all the limitations, but they had no prior estimate for CRS. The OS benefit, although the prior studies had shown about 50% or even 100% improvement in overall survival or doubling, you cannot expect the same when you take patients before neoadjuvant. So the OS benefit, I believe, is a little ambitious. Some people may believe that the OS is actually inflated. What we are seeing may actually be an inflated OS because we are starting patients before neoadjuvant. So if we start calculating survival at the time of surgery, maybe we need to subtract 3.5 months, but that is not actually true because now you are calculating patients who progressed also. So in fact, the survival estimate that is provided is actually an underestimate had you taken patients only at surgery. Now they accounted for 25% or 25% deaths at 4 months, but they did not account for progressions. They accounted for censoring, which would happen later. But this progression turned out to be much more than what they had anticipated. The censoring before CRS was important because it reduces the non-informative events. People progressing before cytoreduction are not informative. And for overall survival, that was okay. But what about PFS and DMFS? It should have been done for those also. Finally, premature termination led to further reduction in power, because of which the overall sample size is not very strong enough for us to detect difference. Now, the biggest problem with interpretation is that cytoreduction and CRS HIPEC arms were different. We shouldn't have had 40% cytoreduction versus 54% cytoreduction in the arms, because that happens before intervention. So there was imbalance, and this imbalance is because of chance. It's a random event which has happened. There were more signet cancers, grade 3 tumors, distant metastasis in the CRS alone arm. which probably led to more progressions in the CRS alone arm, and that led to worse survival in CRS rather than whatever small difference we are seeing in favor of HIPEC in the small subgroups. So very simply, they could have done a regression with these factors rather than just for HER2 and PCI subgroups. They could have done a regression with Signet, but I know that they are limited by the number of patients and the events, that putting in more variables in the regression model would have led to non-generalizability of their results. So if we had to do another thing, we would have to have an RCT again. But this time probably a PCI cutoff of less than 13. Probably take only incidental peritoneal metastasis. There should be no distant metastasis, no ascites. And a better thing would really be to randomize that surgery if CC0 is achieved. The neoadjuvant that we are giving for peritoneal metastasis is quite poor. If you have 50% and 60% progressions, we need to strengthen the neoadjuvant, and probably bidirectional may be a good thing to do to start off with. If we really want to see the benefit of CRS HIPEC, we need to identify patients that would recur in the peritoneum alone, because gastric cancers and colorectal cancers not only recur in the peritoneum, they recur distally also. And if patients have distal recurrences, entire study will be diluted. So that may be a good thing to do in a retrospective to find out which patients are recurring only in the peritoneum, select those patients for future prospective studies. Now, what are my conclusions? My conclusion is that for clinically evident gastric peritoneal metastases, which are clinically M1, radiologically M1, HIPEC, and I don't know, maybe even CRS is not working or not worth. Now, for clinically occult peritoneal metastasis, the question is still open and needs further investigation. Thank you.
Thank you, Dr. Kazi. That was an extremely detailed and extensive presentation, and with thorough explanation about the statistical analysis that was used. Really excellent. Thank you very much for that. I would like to, like you said, like we know that gastric cancer with peritoneal metastasis has been getting evaluated over a period of years, and we have data about CRS and HIPEC with retrospective series and single institutional series, and we have a randomized control trial which was initially done by Yang et al. In 2011, and now directly we had a Rudolph et al. Who did one, but which was versus systemic chemotherapy, CRS HIPEC versus systemic chemotherapy. And after over a period of so many years, we have another randomized control trial. But again, the trial has, as we discussed in detail, so many flaws. So my point was again that if maybe the experts would, Dr. Manish, Dr. Ramakrishnan sir, that if exactly as you said, if we would have randomized after neoadjuvant treatment, we would have been in a better state.
After surgery, you mean?
At surgery, after once the CC0 is achieved, randomize them to HIPEC versus no HIPEC, we would have been in a better position to answer this question rather than having an unselected group where we really don't know what we are looking at and what we are trying to answer. Dr. Manish, yeah.
Yeah, absolutely. I mean, first of all, I think Mufaddal, brilliant job with the analysis of this trial. I don't think anybody else would have done better than you. And immediately, I think for our TMH residents, I'm going to ask you to take a class on how to read a randomized control trial. I think you would be the best person to do that, because all the details, including the log rank versus the Fleming Harrington curve, etc., were really, really nice.
Beautifully explained.
Beautifully explained too. And all the flaws, I don't think you have missed any of the flaw, because I had also taken down few notes. I don't think you have missed any of the flaws, and you started rightly by saying that we must appreciate the efforts. But unfortunately, at the end of the day, despite the efforts, the flaws were just too many which surfaced. And at the end of the trial, we still do not have the answer for which the whole exercise was carried out. So it is, I would still say that this is all in vain, because all the information that we had before is was still available. And I don't think that this trial adds anything new to what we already knew. But the results also tell us that the median survival is 14.5 months when we treat the patients. And of course, it is intention to treat. And we would always do overall survival at the time of initiation of treatment and never from surgery. So that will be right. But the randomization, as you rightly said, for any surgical trial or any intervention that we are testing, which is very specific, that whether addition of HIPEC improves any outcome, I think the randomization should have been definitely at the time of surgery, but and never before that. If we were to test the hypothesis that adding HIPEC makes any difference or not. Otherwise, the trial design is also good. Had the question been something else, that whether any of these make any difference in the outcomes and compare the outcomes with palliative systemic therapies. The other thing which you rightly said, that the CRS alone group probably had the worst biology patients or poorer biology patients with higher number of signatoring cells. I think signatoring cells should have been one of the important stratification point.
Yeah.
If that was to be done. And the other thing which also comes out with this is that the approach used is neoadjuvant chemotherapy followed by CRS HIPEC. Now, even we don't know whether that is the right approach, because signatoring histology, we all know that they respond poorly to the present chemotherapy. And if you are to have more than 50% of patients who are signatoring, you are likely to get very poor responses. Also, the neoadjuvant completion rate with 3-drug regimen was very low in both the arms. It was under 50%, which is not what we see in reality. In reality, we see more than 80% patients completing even FLOT. And this trial majoritarily had EOX, which was the previous original MAGIC. So there was less completion. There was probably higher patients, more than 50% with a high PCI, maybe about 10 could have been there. All these are the flaws, of course. And with all this, I think the problem still remains that whether we should be doing HIPEC and CRS, and the bigger or the important trial is going to be the Periscope 2 trial, because that question is still not answered, whether CRS and HIPEC in today's era with better developed chemotherapy drugs and the immune checkpoint inhibitors which are available, is a HIPEC CRS going to add anything to chemotherapy is still the question to be answered. Of course, what I feel is there is always a role. We all know that selected patients are definitely going to be benefited by this intervention. But for that, we need to have a good randomized control trial, which is similar in design to either Periscope, or we have another trial of such kind where the randomization is done with a better stratification. The randomization is done at the time of surgery. This is what I would conclude at the end of this trial and today's discussion.
Yep.
Excellently put across, Dr. Manish. Do we have Ramakrishnan, sir? As
No,
yeah.
I don't think so.
So we would like to hear your views.
Yeah, thank you. So, firstly, I think I need to congratulate Kazi for such a wonderful appraisal of this difficult to understand trial.
Thank you, sir.
And of course, Manish for also bringing up very important points. Many of the points that I had noted down was quite similar to what both of them said. But I just like to mention a few points. Yet, first glance, this would appear as a negative trial, a trial that was not completed because of poor recruitment. Even I wondered, how did it get published in GCO? GCO is probably the highest impact factor, the ranking journal in oncology. And to publish such a trial in JCO, there must have been something that the reviewers and the editors must have seen in this trial. Frankly, I couldn't really understand what exactly they saw that so important that it has to be published. But in general, even negative trials needs to be published, needs to be discussed, because we learned so much from negative trials. What I learned from reading this manuscript was basically to do with the PICO that we talking about while designing the trials: patients, intervention, and the control. Outcomes, of course, there is very little under the control of the investigators, but patients, interventions, and the comparator, there are some things that we can learn. Coming to patients, Kazi had already discussed the choice of patients was probably not what we would expect in a high-tech trial, because this trial started in 2014. By then, there was enough evidence to suggest that IPCI don't do well in gastric cancer. Less than 7 are the best. So why include patients with a high PCI? If the intention is to show that HIPEC performs better, then I would have preferred to choose patients with PCI that is known to support the effects of HIPEC. Then there were a lot of patients with significant cell cancers. Nearly 40% of patients had ascites. All of these we know are poor prognostic factors in peritoneal metastasis from gastric cancers. There was a lot of imbalance between the two arms, as Kazi had rightly pointed out, especially in the distribution of significant cell cancers between the two arms. We know significant cell cancers do poorly. They do not respond very well to chemotherapy. Probably, like Manish had mentioned, they should have been stratified based on the significant cell histology as well. So that is about the patients. Coming to the intervention, it is disappointing that probably not disappointing, probably expected, and that is what we see in routine practice. Patients progress when they are given systemic chemotherapy. In my own practice, there are a lot of patients after a diagnostic laparoscopy. We would discuss in the MDT and decide that yes, after completion of neoadjuvant chemotherapy, because the PCA is not very high, can consider them for HIPEC. But by the time they complete neoadjuvant chemotherapy, many of them progress. So that is exactly what we have seen in this trial also. So what we need to think, at least in future trials or in clinical practice, is that neoadjuvant systemic chemotherapy is not the best way of neoadjuvant treatment for gastric. There are a lot of literature from Urimara's group and others who have used intraperitoneal chemotherapy, which is testimony to the excellent effects of local intraperitoneal chemotherapy rather than only systemic chemotherapy. So if at all we need to choose neoadjuvant treatment for peritoneal metastasis from gastric cancer, I think it is imperative that at least in future trials, we need to have component of intraperitoneal chemotherapy as well. So maybe the intervention is not a very satisfactory intervention, at least in the neoadjuvant arm. Now coming to the comparator, I was really surprised why they had to choose CRS alone as a comparator. We would normally choose in a phase 3 trial the standard of care arm. CRS is not standard of care in peritoneal metastasis from gastric cancer. Standard of care remains palliative chemotherapy. There are few trials which have shown that isolated metastasis in gastric cancer, metastatectomy or palliative cytoreduction is not going to improve survival. So probably the comparator that I would have preferred would be palliative chemotherapy, which is exactly what the PRISM-2 is doing. By choosing CRS alone, problem is they did not have any baseline value to calculate the sample size, which has led to the sample size probably being overestimated. The survival difference probably being overestimated. So the comparator also could have been chosen better. Now, as he had mentioned that there is a difference in the proportion of patients who actually underwent cytoreductive surgery in the two arms. I mean, there were practically no reason why one arm had to have more progression of disease or less number of cytoreductive surgeries. But the only two reasons other than progression that I could think of was the CRS alone arm had higher incidence of toxicity related to the preoperative chemotherapy. It was 62% versus percent. In practice, patients who experience severe toxicity to neoadjuvant chemotherapy, there is always a hesitancy in considering them for a major surgery like CRS plus IPEC. So I wonder whether that could have been one of the factors that led to less number of patients in the CRS alone arm going on to cytoreductive surgery. The other point is that the CRS alone arm had more number of signet ring cell cancers. Signet ring cell cancers again don't respond very well to chemotherapy. That could have been a reason why the progression rates were probably slightly higher in the CRS. These are some of the points that I had noted down. But what I'm not sure I read anywhere any discussion about why there was such a poor recruitment. I mean, the German cancer society groups, they have done so many practice changing trials, and it probably was not so difficult for them to recruit patients in any clinical trial in Germany. But it is surprising that there was a poor recruitment because of which they had to stop this. So it would be interesting to know why there was a poor recruitment, so that some modifications could be made. At least it would be helpful for investigators in future studies how to improve the recruitment in a trial involving CRS. That is all I have to say.
Thank you, sir, for your explanation. Even I had the same feeling when I read the paper that this is like a routine scenario which we see in our practice, that more than half of the patients will progress on chemotherapy and very few of them will come on table. So rather, it was like this is what is routinely happen. So we really need to select those patients who will benefit with CRS and with or without HIPEC. Again, I would like to really know that we know that intraperitoneal chemotherapy works very well in the neoadjuvant setting in these patients and probably in the adjuvant setting also, as is being practiced in the Eastern countries. So what is the take of the house on using neoadjuvant intraperitoneal treatment in our setting, in our country?
Dr.
Dr. Manish, Dr. Kazi, Dr. Prashant.
Personally, I believe that if we find parietal metastasis, either occult or evident metastasis, should be giving neoadjuvant bidirectional therapy, either in some form. And IP ports are quite safe and easy to place, and they're easy to administer also. Not very logistically difficult as well.
Yes.
I think at present, I agree that we should be doing this without a doubt, because the HIPEC, which is being a one-time procedure, is not an ideal solution for a disease which is peritoneal disseminated. It needs a regular treatment. As we give IV chemotherapy in cycles, we need to give IP therapy also in cycles. And for that, either an adjuvant intraperitoneal therapy in high-risk cases, or in cases where there is already established metastasis. I don't know whether it's a neoadjuvant or a palliative, but that type of a therapy is definitely going to improve outcomes, is what the results have shown so far.
Yes.
At present, we have challenges with logistics, and also maybe some apprehension to deliver this kind of an intraperitoneal therapy, because there is also, I would say, a little bit of a nihilism in terms of treating these cases. We all think, especially the medical oncology group as well, that giving some kind of an intense therapy and landing up in problems in stage 4 cancer, is it worthwhile where we have systemic chemotherapy? That is also one of the challenges. But I think we have to overcome this and get IP therapy more into practice. And as Dr. Ramakrishnan said, future trials should study this neoadjuvant therapy rather than it's the only systemic chemotherapy, and assess the effects. And I think uh, yes, we have the trial, but for now, what we can do is to continue to select patients on the basis of their responses at present, because even if these results are not very great, but we know that published retrospective large studies, we also have some experience at Tata, which is still unpublished. But the cases which undergo complete treatment do enjoy a lot of improvement in survival. The median survival is upwards of 30 months when patients are treated fully, and these are selected cases with kind of low PCI, under 10 PCI. And if you are getting a 30 months of median survival in a stage 4 gastric cancer, I think this is definitely making a difference. The question to how to choose them, it remains individual, and of course we can learn from the experience of the published trials and have a standard policy in your unit or a department as to how to select cases for this intervention. And also the CRS required may not be very large. I mean, most patients would have some response which you would choose for CRS, otherwise you won't choose. And
Yes.
when you have a response, you don't need to do an entire peritonectomy. We have been following limited involved peritonectomy only and not doing any major resections along with it. And I think that is also worthwhile and amounting to benefit to patients. So this is not a very radical or a very morbid surgery that we finally offer in a responding patient.
Yes. So I would really like to put across that we have been doing this intraperitoneal treatment as you have been doing, Dr. Manish. And when we see that there are these, there is immune checkpoint inhibitors, there is HER2 testing, trastuzumab, there is all extensive molecular testing which is happening. And then you consider as against an intraperitoneal port, and the chemotherapy is much cheaper. For our setup, we find it is much more affordable, and as compared to even PIPAC. This port itself cost around 25 to 30,000. That's a one-time thing, and the treatment, the chemotherapy is around 3,000 to 4,000. So it is much doable, and the fact remains that it helps in selecting patients. And some patients do extremely well, and then definitely they can go on for a better prognosis. One more question which I would like the experts to answer is the role for using this Fleming-Harrington analysis. What do you think must have taken the authors to use this as an analysis, just to make something as, to show some statistical significance, or because events we want is close to the intervention? Right. So I really didn't understand that. Why did they go ahead with, this kind of statistical methodology?
So this was decided a priori. So it was
Right.
not that they tried log rank and it didn't keep.
Correct.
No, it was not like that. So they expected a few things. One is because of randomization before surgery. So events which would happen before cytoreduction, they didn't want to at all. So that was censored. Events happening immediately after cytoreduction, HIPEC, could be related not due to the cytoreduction. Maybe they are early progressors, so they didn't want to give too much weight, but you cannot discard them completely. So you give them lesser weight, and as they progress longer, so you expect that if they are really to benefit with intraperitoneal therapy, they would have peritoneal recurrences later rather than earlier. And
Correct.
so let's try to give them more significance.
Yeah.
So I think those were the things in their mind when they chose Fleming-Harrington. Secondly, I think they expected a small sample size. Despite 180, they probably expected that we would be having 50% or so, which would be analyzable. So in such cases, if you have only 2 or 3 patients which are differing, that will never be significant on log rank.
Right.
So I think this could be their forethought. I cannot be sure, but one thing is that it is not a trial and error thing. They chose Fleming-Harrington to begin with.
Right. Because I thought that this was, as a later thought.
No, it was not. It was there in the protocol as well. Because the sample size calculation was based on the Fleming-Harrington rather than this.
Correct.
But even if they have used Fleming-Harrington and whatever. Finally, at the end of the day, it is 14.5 months in both
Yeah.
arms for overall
No,
survival.
no, the importance is because the manuscript mentions that there is benefit in PFS. The
And
manuscript mentions that for CC0 patients, there is OS benefit, there is DMFS benefit.
yes,
But
Oh, but
rightly as you have read out the trial, anyone reading the trial would get it that this is so small numbers which are being compared, and the survival, the difference is usually what we see in some medical oncology trials, couple of months here and there, which is not very meaningful.
yes,
And also, I think one of the other factor which could have probably led to this is because in the CRS HIPEC arm, even if there was no cytoreduction done, I think they gave a HIPEC therapy in about 10, 11 patients.
one patient only.
I think 11 I read.
yeah,
Probably
even I read something around 10, 11 patients.
around
No,
10,
that was
11.
for incomplete cytoreductions.
Yeah,
For
incomplete
incomplete,
cytoreduction.
yeah. So in
Yes.
both arms,
Even if
even
they
in
did not
completely
put,
cytoreduced patients were getting HIPEC.
so it was kind of probably acting as
Palliative.
palliative HIPEC,
Palliative
which
HIPEC.
so you would probably delay some kind of recurrence or something. But anyways, nothing meaningful out of it.
So, how do you think? Any comment on the time of Dr. Aditi has asked a question. Any comments on the time of adjuvant chemotherapy?
Hmm. Slightly longer.
Yeah,
despite,
50.
despite
That's also a
not without multivessel resections, with length of hospital stay, which was very acceptable, only for 13 and a half, 15 days. The adjuvant was quite delayed. And I don't think there were any surgical toxicities were also quite minimal. Surgical reintervention rates were less than 20%. Despite that, adjuvant was very delayed.
yeah, not sure about that reason. If
Yeah.
patients have
Both problems. Actually, the new adjuvant also had more toxicities than expected. Completion rates were poor, but we cannot compare their completion rates and toxicities with M0 patients, which is our background.
true.
And same problem with adjuvant.
True. And probably, as we saw, there are patients who had ascites, which means that there must be other problems also associated. When you have ascites, whether it is malignant or nutritional, usually those patients tend to fare poor as compared to those without ascites, even if they have peritoneal disease. So, in terms of completing the therapy, undergoing surgery, then starting therapy again, it is challenge in patients who have ascites.
That's correct. Even the Phoenix trial, I think they finally concluded that the negative result of the Phoenix trial was because of a higher proportion of patients with ascites.
Yes.
Yeah.
Yeah, there are a lot of things that could be improved upon that we can learn from this trial. Unfortunately, this adds very little to change of practice as of now. Let us hope the Periscope trial offers a better picture and a role for high-tech in the current treatment system.
So, sir, for the benefit of everyone, if a patient in OPD is with gastric cancer peritoneal metastasis, how should we go ahead with the planning of the treatment?
Well, I think you need to have your medical oncologist on board. If it is not discussed in a proper forum, the patient is likely to go down the path of multiple lines of therapy, probably targeted therapy, immunotherapy. But there is evidence to say that local intervention in the form of CRS and various forms of intraperitoneal chemotherapy will help a select group of patients. So, proper discussion in the MDT, identifying with the currently available evidence who are the patients likely to benefit, low PCI, probably not signatory cells, absence of ascites. These are the patients who are likely to benefit from sort of neoadjuvant IV plus IP, the so-called bidirectional treatment. It is easier said than done. In reality, most of us don't practice IP chemotherapy because of various reasons. But if the facilities, the resources, and the opportunity is available, I think a combination of IP plus IV chemo, and in those who respond well, offer them a cytoreductive surgery, probably with HIPEC. That would probably be the way to manage patients. Current point of view. Of course, immune checkpoint inhibitors have completely turned the management of metastatic cancers of various sites upside down. So that is something that we'll have to factor in. The patient is affordable, and if he asks a question, I mean, do you think immunotherapy is going to be better than CRS? And I frankly don't have an answer. Rather than looking at them as two separate treatments, if you are somehow able to integrate them in the same treatment pathway, that would be probably the best that we could offer.
And what would be the PCI cutoff that would you choose, sir, for deciding that you would like to go ahead with CRS and with or without HIPEC?
Current available evidence suggests less than or equal to 7.
Yes.
There is a suggestion from this paper that even above 7 benefits, but I think that is just a hypothesis. Not assume that they will actually benefit. So at the moment, limited PCI less than or equal to 7. Probably more important or equally important, like the PCI, is the distribution of the peritoneal metastasis. Distribution, I mean, presence of peritoneal metastasis over the small bowel, century or serosa. Even if the PCI is less than 7, they probably are not going to do. So you need to look at both the PCI as well as the distribution of.
What do you use, Dr. Aruna, for intraperitoneal paclitaxel?
No, we have started with docetaxel. We use docetaxel cisplatin IP and docetaxel on day 1 and docetaxel cisplatin on day 8 as IV with oral capecitabine. We have done IP paclitaxel only in one patient who had progressed on with signet ring, progressed on docetaxel and cisplatin. So we thought maybe we should try the Lu et al. Protocol of 80 milligram per meter square intraperitoneal paclitaxel. So that is just one patient we have right now.
How is the tolerability with dosi and cis?
It's the patients who are responding are doing quite well, and few of them have come for surgery. The patients who are not responding, they are not responding. Yeah. There are a few questions on in the chat, like what stratification factors would be used, to decide future trials, comparing for CRS versus systemic chemotherapy, and whether a cytology positive ascitic fluid would be considered for HIPEC.
Yeah, I think so. If we learn something from this trial is that we cannot ignore signets. So over HER2 and PCI alone, at least histologic subtype, and like Dr. Aditi pointed out, maybe primary tumor site also, because both distal and proximal stomachs are different cancers.
Yes.
The question of ascitic fluid cytology alone being positive, I think, will be answered partly by the gastric chip study once
Yes.
Yeah, but at present, yes,
Yes.
we would take those patients. Yes, that question will be answered, but at present, only cytology positive. So far, we had thought that these are probably the best patients to undergo HIPEC who have no disease, but we never know. These might be bad patients also, even in absence of macroscopic disease. If cytology is coming positive, maybe something which is there biologically or something else different in these cases also. But at present, these are simpler to treat in the sense you don't have to do any additional CRS. You have to do a gastric resection and add an HIPEC, or probably add something like an IP adjuvant or neoadjuvant setting.
So my question is that when we counsel a patient for HIPEC, what do we tell them? If we consider a patient for CRS, good response to neoadjuvant chemo or IP treatment along with IV treatment, should we say HIPEC or not?
I think so. At present, yes. But in addition to what we discussed before about selecting patients or treating patients, if we see patients in outpatient who have peritoneal disease seen on the CT scan, it is unlikely that that patient of gastric cancer is going to be for a CRS HIPEC. So you all know that we in Tata at least have a standard policy of doing a staging laparoscopy.
Yes.
I think with that we pick up more patients with who have smaller amount of peritoneal disease, which is really low PCI, less than 5, less than 3, which is very difficult to pick up if you are not doing staging laparoscopies as a routine pre-operatively in locally advanced gastric cancers. And then what happens is you are going to probably miss them if they respond to chemotherapy, because smaller volume diseases can respond and you may not see the peritoneal disease post neoadjuvant therapy, and then you are
Yes.
immediately going to miss a chance. So before the indication for was different for staging laparoscopies, I would say, but now that we know that low PCI disease can be treated, I think it is imperative even more that we start doing staging laparoscopies as a routine. And these cases are probably the ones which are the best suited for CRS and HIPEC.
Yes.
If you're already seeing some disease on these scans, then
They are
I
less likely.
think that you are going to have a low PCI or anything.
Yes.
Then the outcomes are going to be different if you start treating them. So that is what is also a difference.
One of the
If
questions.
something gastripec has answered, is that clinically evident peritoneal metastasis, nothing, HIPEC is definitely not working, if at all, if at all.
If at all, yes. There is one question in the chat box. Somebody who has been taken for a robotic gastrectomy and turns out to be cytology positive, I think on frozen probably. Will you convert to HIPEC? Anybody would like to take that question?
It's
It could
extremely
be sense-
unlikely to get a positive cytology report on table within. I mean, there are some methods that can be done, but
Yeah.
probably may not be as accurate, and more importantly, the yield of peritoneal lavage cytology, at least in India, is pretty poor.
Yes.
And unless you have consented the patient for HIPEC, I don't think that is a possibility. So you might just have to close just the treatment options and then decide how to do it.
Yes. Yes. Prashant, you have any comments, any questions?
No. Actually, I mean, very well presented. Coming to the last one, I think if you wouldn't have docked the robo, so I think there's no need to worry. If you had planned that you're planning to send a cytology, then you would wait for the cytology report rather than docking your arms. So I think there's no question that, I know the question might have been worried that you've already docked, a lot of financial thing have gone in, and then what do you do then? But if you had a plan of sending a cytology for frozen waiting, then you would have anyway not docked. So I don't think it should be a problem. I mean, and just because you're using a robo, it doesn't mean that you should change your principles of operating. If you're planning to send a cytology, wait for it, and then it remains the same whether it's laparoscopy, open, or robotic.
But what if it is after neoadjuvant? But
yeah, so after neoadjuvant, then if you've already decided. So how routinely do we send peritoneal fluid cytology after neoadjuvant, and that too for a frozen section? I don't think it's a practice anywhere.
Yeah.
The only reason you would send it is if upfront it has been positive,
Upfront,
and
yeah.
you want to make sure that it is converted to negative. That scenario, you would definitely want to wait to know for sure that it is converted.
Yeah, exactly, sir. So, I mean, but that's a scenario there, you had initially positive. But do you, just a question, since you brought up this, that post neoadjuvant chemotherapy, you would send it. But does it really make a difference? I mean, would you wait? Okay, if ascitic fluid cytology comes negative, let's say if it comes positive, would you not offer surgery for this patient post NACT?
Yeah. In practice, I do not practice peritoneal lavage cytology because the yield has been shown to be very poor. But if your practice is to perform peritoneal lavage cytology, and if it comes as positive, and you have given the patient some form of neoadjuvant treatment, and you would want to take up that patient for surgery, there is good evidence from Japan, including Unemura's group, that
Yes.
those who have converted from a positive to negative do well, whereas those who continue to remain positive, they do not do well at all. Question of whether you would offer surgery or not is different. We continue to offer surgery for patients regardless of their Lava cytology results. Probably what in addition you would do is you might add HIPEC, the hope that that should take care of osteoporosis.
Yes, sir, I agree. It will be a very good prognostic factor, but I'm not sure at this moment whether it would change the line of management. And right, as you said, you may add HIPEC because I think probably that will be the best ideal scenario to add on HIPEC probably.
Yes. There is one more question on initial staging laparoscopy. Pre-NACT patient was noted to have disease over the diaphragm. Post-NACT, the disease has responded. Is it justified in doing a limited peritonectomy based on the initial staging laparoscopy findings? What is being followed by the house?
Yeah, I think Kunal only has asked this, who's just now with us, and we have had a recent patient. But yes, of course, the practice is to remove the part which is involved, which we knew beforehand, and it's always limited that we follow. It's never the complete, unless it is involved, yes, of course. Otherwise, we haven't had that practice of removing the entire peritoneum so far. And there is neither any level of high level of evidence to suggest one way or the other. So the aim is always to keep the morbidity to the minimum and yet offer whatever best we can. And limited peritonectomy of the involved site should be performed. But unless if you have a complete response, which with nothing seen, then we have to really, I think also there might be some role of observing that area and going ahead with surgery of the primary area, and then hoping that the HIPEC would also take care of that area. Although this is, I don't know whether this would be the practice by everybody or what would be the philosophy for everybody with this. But if it is not adding too much of morbidity, then I think removal of that site is what would be a practice from my side at least. I don't know about the others, how they would approach this.
What
Mute your.
they definitely take it out because there was disease and there could be microscopic disease. But again, taking into account that how the patient has been doing throughout the surgery and whether your additional stripping would add to any morbidity. Other than that, I think we should go ahead, and if there was a documented disease before, then that area of peritoneum should definitely come out.
Because you want to also see if there is a histological response in that for better prognostication. But when we are doing this surgery, we have to also gauge overall the patient status, the lymph node status of the tumor, which we have not discussed yet, at least today. But yes, when we are planning something like a high PCI, etc., one of the other stratification factors also should be what is the lymph nodal status, because that also is a very important prognostic indicator. And if you have a metastatic disease, which is with a bad lymph node disease, which is kind of an N2 or N3, upper N2 disease or an N3 disease, then it is more towards palliative always. And then in that situation, definitely don't go for any kind of an aggressive treatment option.
So limited field or involved field peritonectomy is okay for gastric cancers. There's no data for total peritonectomy. And secondly, from gastripec, again, we have some secondary data that the histological regression rates are less than 15%. So if it was involved before, it is very wise to remove it even later.
Yes. Are there any more questions? In patients not being considered for CRS, was the best time to introduce IP chemo? Dr. Aditi is asking, in patients not considered for CRS, what's the best time to introduce IP chemo and what's the opinion of the panel? Means patients who are, I think, progressing or having response on neoadjuvant IV chemotherapy without the targeted therapy and not becoming amenable to CRS. So
I think by philosophy, if no distant mets, only peritoneal, isolated peritoneal progression, they are good candidates for introducing IP therapy in either form, whether it be PIPAC or bidirectional or IP alone. Whatever.
But this situation is palliative, and when it is palliative, we already have this practice. Whether when there is symptoms, then we generally tend to add it, which is like ascites, which is increasing, causing
yes.
problems. Otherwise, I don't know when, as a routine, if you would add an IP therapy to a patient, because we don't have much data yet to support that routine use of an IP therapy in a palliative setting without symptoms is better. I don't know, correct me if I'm wrong, but I think if a patient is stable, who is having no food intake issues, nutrition remains maintained, patient is of course not for a curative surgery, but is on systemic therapy, then to add a IP therapy to offer better control, I'm not sure whether that adds. For better palliation, yes, of course it does add. We have a lot of data on that, and it could be an IP, it could be a HIPEC at times, it could be a PIPEC, but routinely adding an IP therapy as an alternative or as a second option to surgery or curative, I'm not sure.
Here I would like to mention about one of our patients who was around 65, had a lot of comorbidities. We start and peritoneal disease on staging laparoscopy, T3N plus disease, and we started him on IV systemic chemotherapy and not much response post 4 cycles, and he was definitely not going to come up for surgery. So we introduced an after counseling and consenting, we introduced an IP port. And actually did quite well with IP chemotherapy, and there was a good response, and we were able to do CRS in that patient. So maybe in highly selected group, and once the patient understands the additional implications of having a port, it can be considered. So yeah, maybe it can be considered in patients, or it may be upfront also can be considered if the patients understand and they are consenting for the treatment.
Actually, Dr. Manish, there may be a flip side to that also. Suppose if the patient becomes overtly symptomatic, then the time is probably lost to give IP therapy.
Yes,
So
I don't
intractable ascites, I agree. Intractable ascites or progressing ascites. But if bowel obstruction, gastric obstruction, then those may be very late. At least that is what happens with colorectal cancers. If they become symptomatic, then there is hardly.
Nothing works.
No, I understand, but doing an IP therapy will solve all these problems and make life better. That we don't know as yet. We need
Yes.
some evidence for this to make it as a standard. So that is why we can't give it as a blanket. But as Dr. Aruna said, that yes, in a motivated patient, selected patient, after counseling, this can be offered as an option. But this is not a routine option that you would give to any patient, because we don't know. Because IP therapy, we all like it because the data is saying, but we have to also see in reality how the patients are doing who are not undergoing surgery. What is the long term? I mean, after 3-4 sessions, how much is the problem caused by the IP also?
Yes.
So all that needs to come out in some randomized trial first, and then of course we can implement that.
So I think it's time to wind up. If there are no further questions, to just summarize that we need more data, and we need to select our patients more appropriately and conduct studies which may answer the questions properly. An excellent discussion. All of you, thank you so much. Dr. Aditi, if you want to add something. Dr. Ramakrishna sir has already left. Dr. Rudra, I think, has left. So, thank you, Dr. Kazi. Thank you, Dr. Manish.
Thank you.
Thank you, Dr. Prashant. Thanks all for attending. Thank you so much.
See you next time.
Thank you.